Hello, this is Ruben Major. I am an instructor, program director for Arizona, and chief executive officer of EMS University. In this particular section, we're going to be discussing the focus history and physical exam. This is a relatively short section. However, the information in here is important for you to know, mainly for purposes of testing and also for the purposes of going through this focused history and physical exam when you are in the field. What you're going to want to do, just generally speaking, when you have a focused history and physical exam, is you're going to want to be obtaining a chief complaint, evaluating the chief complaint, conducting the physical exam, and then obtaining baseline vital signs. So this again is a very focused history and physical exam. This is not a rapid assessment by any means. So the first thing you're going to want to do is get the chief complaint of the patient. And usually you can obtain this information very easily by asking the patient, what's the matter, what's wrong, what is the particular reason why you called 911, those sorts of things. They always say that it is a good idea to come in and introduce yourself, but this is a very informal process. Remember that you are trying to establish a relationship with your patient so that you're able to do a better job with your assessment. So the first thing that you should do when you come in after you introduce yourself is to ask the patient what's wrong and obtain the chief complaint. Now, when it says that you're evaluating the chief complaint, basically what you're doing is you're going to be tailoring and centering in your questions along with why the patient is complaining of the particular thing that they are. And we'll kind of go over this very, very briefly. Again, this is a short section and a couple of slides about the trauma assessment and medical assessment at this point. So when you conduct this questionnaire, or when you do this questionnaire, you're going to conduct a physical exam as well. These are things that should be done simultaneously. Now, when you are in a skill station, if we're talking about if you're going through a skill station, or if you're doing a practical skills competency, what you're going to want to do is make sure that you kind of verbalize everything that you are doing. In real life, obviously, you're not necessarily verbalizing every little thing that you're doing, but it isn't necessarily a bad idea to verbalize most of what you're doing for the patient, for their comfort, and just so that you can give them an idea of what kinds of assessments that you're going to be doing with them. So you conduct this physical exam, and then you obtain baseline vital signs. This is a very, very good start and kind of will help you as far as your overall direction with a patient throughout the entire process. So again, obtaining vital signs is an essential part of that. So again, with the focused history and physical exam, what you'll want to do is go back and reevaluate the mechanism of injury and think about this. Is this a significant mechanism of injury? Now that you have the patient's chief complaint and you have the patient's have evaluated the chief complaint, what you're really doing now at this point is evaluating this mechanism of injury or even the nature of illness on the basis of what the chief complaint is. Is the patient unresponsive? Are they disoriented? Can they participate in the exam? So do you have a patient that is unconscious, or do you have a patient that is having issues with their mental status? And is the patient under influence of drugs or alcohol? So when you're looking at this, you're looking at kind of the bigger picture. And can they participate in the exam for if they are intoxicated or are under the influence of drugs? For car accidents, did you know that according to the CDC, the motor vehicle accidents are the top killer for age 5 to 34 in the U.S.? That's a scary statistic. The scariest thing about the statistic, I would have to say, is going to be our pediatrics. The fact that people who aren't even driving a car, this is going to be the number one killer for them. kind of a scary thing if you think about it. So trauma assessment, again, is this a significant mechanism of injury? We are assessing the chief complaint and reevaluating it on the basis of the mechanism of injury, and we're doing a rapid trauma assessment. We've already done the DCAP BTLS, and so now we're doing 2 sets of vital signs and looking for trending. This is a rapid trauma assessment with this, apologize for that, with a significant mechanism of injury. Now, when you're discussing a not a significant mechanism of injury, then we can go through this focused assessment that we discussed earlier, assessing the chief complaint, and then obtaining those 2 vital signs. Sample, remember signs and symptoms, allergies, medications, past pertinent history, last oral intake, and E stands for events leading to. Now, events leading to the illness or to the injury. Funny thing is, the E comes at the very end, but the E is actually going to be the most important information that you're going to obtain from the patient. Because really what you're doing is you're evaluating their chief complaint more specifically, and you're kind of getting to the bottom of things. And this is one of the things that many providers often fail, is they do not get this information from the patient, and it really does have a negative impact on how the patient's treated, and then also what their disposition is eventually in the emergency department if they end up being transported to the hospital. So very, very, very important to obtain the information related to the events leading up to the illness or to the injury. So what does that mean? That means what happened to you. Can you tell me when it started? Can you tell me when it ended, or has it ended, or what makes it better, what makes it worse? Remember, this is kind of, some of this also touches other types of assessments, but it's the same general idea. So, what is it exactly that has caused this issue to happen to you in the past? Has it happened in the past? What did you do to fix it the last time? Have you gone through surgery for this sort of thing? All of these questions are really important for you to ask, and even side questions relating to this question, so that you can get a more accurate depiction of the chief complaint of the patient. So again, sample, and then that E is so very important for you to obtain. And then finally, a medical assessment, responsive patient. So if we have a responsive patient, we're going to be assessing the chief complaint, and then obtaining the signs and symptoms. Kind of talked a little bit about this in the trauma section. So OPQ or ST stands for onset, provocation, quality, rate, severity, and time. Again, onset, provocation, what makes this worse? What makes it better? Quality, can you describe the pain? What kind of pain is this? Tell me how it feels. Now, you might be tempted in a moment of awkward silence to interject certain terms in there, such as dull, aching, sharp. Don't do it. It really is no benefit to you or to your patient to give them leading questions in this particular area. They will describe the pain for you, and you just got to give them a little bit of time. Don't give them a list of multiple choice questions. Just have them answer it in their words. So again, can you tell me, what does the pain feel like? And you wait, just like that. And the reason why you wait is because it does take a little bit of time for the patient to think sometimes, and you need to give them time to be able to answer that question. Okay, and the next thing that we have is radiation. Now, I think I might have said something before, but this is radiation. So basically, where does the pain radiate or does it radiate anywhere? If they have pain in their chest, does it radiate to their jaw? Does it radiate to their arms? So again, ask them these questions. Don't necessarily give them any leading answers. Have them answer them in their own words. Remember, you don't want to influence these questions. You just, so that you can put it on your piece of paper, you want to answer these questions or ask them these questions so that you get an appropriate diagnostic of the patient, so that you can help them out in the future, in the near future, for their medical treatment. And then severity. How severe is the pain? And again, when we ask this question, we need a baseline. So, what is 0 and what's 10, or what's 1, what's 10? 1 is relatively no pain at all, and 10 has got to be the worst pain ever. So 10, I always say, is the worst pain you've ever had in your entire life. So that would be the question. Can you tell me, on a scale of 1 to 10, 10 being the worst pain you've ever had in your entire life, what kind of, how would you rate the pain that you're having right now? And the answer to that question is going to be a lot better if you give that 10, because they'll think back to what the worst pain they've ever had in their entire life is. And that's a good baseline for us. It's a little bit more objective than just, tell me what the pain is on a scale of 1 to 10. And then time. So with time, this is a very simple one. When did this start? And if it did end, when did it end? And then you do your focused medical assessment or detailed physical exam here. And again, this is just basically asking more specific questions related to the particular illness. And the detailed physical exam, obviously, you can do that at the same time that you're doing the focused medical assessment. So again, sample and then baseline vital signs. Make your transport decision at this point. Is the patient going to be transported rapidly, or is this a patient where you can benefit, or where they can benefit more from you taking your time to get them in the ambulance and to the hospital? So just sort of think about these things. Obviously, the patient's going to need to be transported to the hospital as soon as possible, but is this a patient where we really need to just hurry up and get them in the ambulance as soon as possible, or is this the kind of patient we can take our time with? And then we have an ongoing assessment. For the ongoing assessment, we're going to be continually evaluating the patient. And then also remember, for your vital signs, you'll be taking them every 5 minutes in an unstable patient and every 15 minutes in a stable patient. For an unresponsive patient, the sequence of events is relatively similar. However, we're going to have rapid medical assessment, meaning that we're going to be doing this kind of rapid head-to-toe exam, and then you're going to be doing baseline vital signs, sample history from bystanders and family, and OPQRST as well, if you can. At this particular juncture, the most important thing that you do is get information from the family about the situation that the patient has been in. If you have family around, if you have bystanders around, which most of the time you will, you should be asking them these questions. You should be asking them any details that you could possibly get from them about what happened, because that information is something that cannot be obtained in the emergency room usually, unless of course somebody comes there later. But again, very important for you to have this information for them so that they can so that the patient can be treated more appropriately later. So questions are extremely important in the unresponsive, unconscious patient. And then make a transport decision at this point. Obviously, the transport decision with an unresponsive patient is that they are unstable, and so therefore you're going to be rapidly transporting them. And then for your ongoing assessment, you're basically doing the same thing as before. Every 5 minutes, again, vitals, but also for ongoing assessment, if there's anything new creeping up, or just kind of keeping an eye on the things that are happening with the patient, you want to make sure you do that. And that will do it for this particular section.